guys, welcome back. This month I started with a lecture series in immunology, and in last lecture I have covered the process of leukocyte adhesion and migration. In this lecture I will be covering the primary immunodeficiency disorder, leukocyte adhesion deficiency. So before starting with LAD or leukocyte adhesion deficiency, let us revise when do we suspect LAD. When a patient who's mostly a child comes to the clinic with a history of recurrent infections, we suspect primary immunodeficiency disorder in that child. So, there'll be a history of the infection starting at birth or at an early age. Now, we will look at the site where the infections are recurring. Now, if there is recurrence of infections at a single site, that is, one organ system is involved, it can be a normal variation. Or it can be because of atopy. Like in recurrent sinusitis, atopy can cause recurrent infections of the sinuses. Or because of anatomic abnormalities like tracheoesophageal fistula can cause recurrent pneumonias, or because of presence of diseases like cystic fibrosis, patient can have recurrent pneumonias, or because of ciliary defects also, patient can have pneumonias. So these will cause recurrent infections in one organ system. But if the patient has recurrent infections at multiple organ systems, we suspect an immunodeficiency disorder in that child. Once we suspect an immunodeficiency, we need to identify whether the defect lies in the T cells or the B cells, phagocytes, or complement. So, if the patient has recurrent viral, fungal, or opportunistic infections, then it points towards the presence of a T cell disorder. However, a recurrent bacterial or a recurrent fungal infection, that is normally by the common pathogens, if it is present, then it will be pointing towards B cell, phagocytic, or complement disorder. So, presence of opportunistic viral or fungal infections point towards the T cell disorders. Viral infections do not occur in B cell, phagocytic, or complement disorders. Bacterial or a fungal infection, which is by common pathogens, occur in B cell, phagocytic, or complement disorders. Now, among the three types, we determine the immunoglobulin levels. When the immunoglobulin levels are low and there's a poor antibody response, then we can do the lymphocyte phenotyping and we can know the B cell disorder that is present. Now, there can be presence of normal immunoglobulin levels but an abnormal number of neutrophils. That is, the neutrophils can be low or the neutrophils can be high. This will amount to abnormal number of neutrophils or abnormal phagocytosis. Abnormal phagocytosis will be present in phagocytic disorders, which I'll be discussing. However, if there is presence of normal neutrophil count as well as normal immunoglobulins, then it will point towards a chronic granulomatous disease, that is CGD, in which there is abnormal oxidative burst. But the main thing to remember here is that we have to know that if there is presence of bacterial and fungal infections by common pathogens and presence of an abnormal neutrophil count, it will point towards the presence of phagocytic disorders. Now, the phagocytic disorders, I have told you that it can be in presence of abnormal neutrophil count, or the neutrophil count may be normal, but the function may be abnormal. Neutrophil count is normal. So, abnormal neutrophil count may be high or low, while normal neutrophil count, the function is abnormal. So when function is abnormal means the respiratory oxidative burst is abnormal as seen in chronic granulomatous disease. And abnormal neutrophil count, high or low, I'll be discussing now. So there are various congenital neutrophil or phagocytic disorders. There can be congenital low number of phagocytes as seen in severe congenital neutropenias. I have already discussed about the severe congenital neutropenia in a previous lecture, link of which is given above. So, severe congenital neutropenias are the neutrophil defects present since birth, affecting the uh, differentiation of neutrophils and thus the phagocytic function. Next, the defect can lie in the motility of the neutrophils, and this will lead to an abnormal neutrophil function because they cannot locate to the site of infection or inflammation or injury. That is, defective migration of phagocytes to the site of infection or inflammation, and this defective migration occurs in leukocyte adhesion defect, which I will be discussing in this lecture. Other defects can be the defect in the oxidative respiratory burst, which I told you is associated with a normal neutrophil count but an abnormal neutrophil function. So, a defect in the oxidative burst is found in chronic granulomatous disease. Other diseases of phagocytic function include Mendelian susceptibility to mycobacterial disease, or MSMD in short, which is primarily a macrophage disorder. And the last type of phagocytic defect is pulmonary alveolar proteinosis, or PAP in short, which is caused by an impaired alveolar macrophage function. Okay, so there's an impaired alveolar macrophage function that leads to abnormal accumulation of surfactant derived lipoprotein compounds within the alveoli of the lung. Okay, so these surfactant lipoprotein molecules, they accumulate in the lung alveoli in pulmonary alveolar proteinosis because of an impaired alveolar macrophage function. So these were the various types of congenital neutrophil or phagocytic disorders. The main phagocytic disorder I'll be discussing in this one is the defect of motility of the neutrophils or defect of migration of the neutrophils to the site of injury or inflammation or infection. So this defect is found in leukocyte adhesion deficiency. So now the question comes, when do we suspect a leukocyte adhesion defect or deficiency? So if there is in the history presence of recurrent bacterial infections uh, and a lack of pus formation during that infections, it points towards a leukocyte adhesion defect. Also, in the patient, there will be increase in the number of circulating neutrophils in the blood. That is, there'll be increase in the TLC count, mainly comprising of high neutrophil count or neutrophilia in the blood. But remember, such a patient, though has increased neutrophil counts in the blood, he or she will not have high neutrophil count at the site of infection. For example, in case he or she develops a skin infection, the neutrophils will be unable to migrate to dermis to contain the infection. Therefore, classically, there would be absence of neutrophils in the dermis or epidermis as noted in skin biopsy samples in cases of skin infection. So, recurrent bacterial infections with lack of pus formation, which is very characteristic, and a high neutrophil count in blood, but absence of neutrophils at site of infection, classically point towards leukocyte adhesion deficiency. Now, in this algorithm, we'll just revise when do we suspect a leukocyte adhesion defect. So, whenever a phagocytic cell defect is suspected in presence of severe bacterial or fungal infections, if there is neutropenia present, then we suspect a severe congenital or cyclic neutropenia. But if there is no neutropenia, and there is presence of a leukocytosis, that is increase in the TLC count or increase in the neutrophil count, then we can consider a leukocyte adhesion defect. So this was a brief introduction to the leukocyte adhesion defect. Hope you all liked the lecture. Don't forget to like, comment, share and subscribe to my channel. If you like my videos and want to get regular updates for the newly uploaded videos in medicine, kindly hit the bell icon. For more immunology videos, follow the link to the playlist named Immunology Made Easy. Thank you.